Saddle up for a wild ride, VETgirl Pack. We're headed to the heart of Music City for VETgirl U this summer, so mark your calendar to join us for a rootin' tootin' good time, June 27th to 29th, 2025 at the Renaissance Nashville Hotel. We're bringing the heat with hot chicken, honky tonkin', and some seriously amazing CE.
Greetings, VETgirl podcasters. It's time to introduce you to the cure for hypertrophic cardiomyopathy in cats. Ha, bet that got your attention. Well, we don't want to get ahead of ourselves, but it is at least fair to say that the subject of today's podcast, Rapamycin, is perhaps the most promising therapy to target the underlying disease process that occurs with hypertrophic cardiomyopathy that we have ever seen. And that really has been the problem historically, right? Is there anything we can concurrently do that we know slows down the disease? To this point, the only therapies we have evidence to consider in subclinical hypertrophic cardiomyopathy are antithrombotics, which we initiate once we identify specific risk factors associated with arterial thromboembolism, such as left atrial enlargement, spontaneous echocontrast, or intracardiac thrombi. But even then, we're simply trying to reduce the risk of an outcome from the disease. We're doing nothing to delay the progression of the cardiomyopathy itself. Heck, at least in dogs we have pimobendan, right? Remember, hypertrophic cardiomyopathy, or HCM, is diagnosed upon identification of concentric left ventricular hypertrophy on echocardiogram in the absence of aortic stenosis or any systemic disease process that can cause hypertrophy secondarily, such as systemic hypertension, hyperthyroidism, or hypersomatotropism. With progressive disease, cats with HCM can become at risk for congestive heart failure, arterial thromboembolism, malignant arrhythmias, and sudden death. Therapies that target the underlying disease process itself and/or improve myocardial function would provide the best opportunity to delay or reduce the risks of these outcomes. Rapamycin, alternative name which I might mispronounce, sirolimus, is a macrolide. It inhibits the mechanistic target of rapamycin, aka mTOR. Never heard of mTOR? You need to get out more. Oh, goodness. Essentially, mTOR is a serine threonine protein kinase that combines with other proteins to form either mTOR complex 1 or mTOR complex 2. Both complexes play vital roles in embryologic and postnatal cardiovascular development. mTOR C1 promotes anabolic protein and lipid synthesis, reduces cell autophagy, aka internal cell cleanup processes, and enables myocardial adaptation to mechanical overload. mTOR C2 is more directly involved in glucose and lipid metabolism and cell structure and cell survival. The balance between mTOR C1 and mTOR C2 activity enable myocardial cells to remain healthy. Interference with this balance leads to cardiovascular disease. Activation of mTOR C1 can lead to pathologic hypertrophy and subsequent cardiac dysfunction. mTOR C1 is sensitive to rapamycin, while mTOR C2 is relatively insensitive, requiring more prolonged exposure to rapamycin to be inhibited. One side effect of such prolonged exposure is glucose intolerance and insulin resistance. The strategy of intermittent rapamycin dosing in mice appears to counteract the negative effects of prolonged mTOR C2 inhibition while sustaining mTOR C1 inhibition. Data in mice as well as human renal transplant patients has demonstrated reversal of pathologic left ventricular concentric hypertrophy, and that's where the excitement for possible use in hypertrophic cardiomyopathy lies. A new formulation of once-weekly delayed-release rapamycin has been developed, although it is not yet commercially available. So Kaplan et al. Wanted to evaluate if rapamycin worked in cats with HCM in a study entitled Delayed-Release Rapamycin Halts Progression of Left Ventricular Hypertrophy in Subclinical Feline Hypertrophic Cardiomyopathy, Results of the RAPACAT trial. The purpose of the exciting study presented here was to evaluate safety of this formulation, as well as efficacy in delaying or reversing hypertrophy in cats with subclinical HCM over a 6-month period of time. The authors hypothesized that rapamycin would be both safe and effective in this regard. The study was designed as a randomized, double-blinded, placebo-controlled clinical trial at 2 sites. Cats had to be less than 12 years of age and weigh over 3.3 kilograms. Cats had to have been diagnosed with HCM on echocardiogram due to the presence of left ventricular wall thickness, symmetric or asymmetric, exceeding 6 millimeters, and had to be clinically asymptomatic. At the time of the study entry, all cats underwent an exam, echocardiography, radiography, electrocardiography, Doppler blood pressure, which is a must in any aging cat, any cat with a heart murmur, and any cat with renal disease, really just any cat in general, and a variety of lab work including hematology, biochemistry, total T4, fructosamine, NT-proBNP, cardiac troponin 1, and urinalysis. Owners also completed a feline quality of life questionnaire. Cats were excluded if they had a moderate or severe version of the obstructive form of HCM, had concurrent cardiac diseases, systemic hypertension, which was defined as a systolic Doppler blood pressure of greater than 170 millimeters of mercury, hyperthyroidism, diabetes mellitus, renal disease, anemia with a hematocrit less than 25%, congestive heart failure, arterial thromboembolism at any time in their history, or cardiac arrhythmias warranting treatment. They were also excluded if the owner could not reliably orally medicate or the cat had been receiving any of a wide variety of medications listed in detail in the manuscript, including corticosteroids. They were not excluded if they had been receiving nonsteroidal anti-inflammatories, antibiotics excluding the macrolides, clopidogrel, or angiotensin-converting enzyme inhibitors. Upon enrollment, cats were randomized to one of 3 oral treatment groups: placebo, delayed-release rapamycin at 0.3 mg/kg once weekly, which was considered the low-dose group, or delayed-release rapamycin at 0.6 mg/kg once weekly, which was considered the high-dose group. These dose ranges of rapamycin were selected based on prior data from the study sponsor indicating them to be safe in cats. Cats then returned on days 60, 120, and 180 for examinations and laboratory assessments. Echocardiography was repeated on days 60 and 180. Owner compliance was rigorously monitored. The investigators were blinded to the treatment group unless a medical issue arose for the cat that necessitated unblinding. Cats could be removed from the study if owner compliance was poor or complications arose such as cavity effusions, cytopenias, organ dysfunction, diabetes mellitus, or systemic hypertension. The study sponsor could also request early termination of the study. A statistical power analysis supported that at least 36 cats would be required to be enrolled to detect a change in wall thickness beyond that which would be potentially attributable to biologic variability. The primary measures of efficacy were based on echocardiography and included maximum wall thickness change as the primary endpoint, and maximum left atrial diameter, maximum interventricular septal diameter, and maximum left ventricular posterior wall diameter independently. The statistical analysis was robust and beyond the scope of a podcast, and also liable to make you turn off this podcast if I rehash it, but it did directly address the effects of not only treatment and time independently on efficacy and safety, but the interaction of these 2 variables. So, the stage is set. What will rapamycin do for these cats? 6 months is not a long period of time, so if it shows the ability to halt or regress hypertrophy over such a short period of time, then it's going to be time to take serious notice. Drum roll, please. Results. 53 cats were screened and 43 ultimately were enrolled. 36 cats completed through day 180. Of the 7 enrolled cats who did not complete through day 180, 5 of them were in the high-dose rapamycin group, and the reason for exclusion included loss of follow-up, owner withdrawal, development of congestive heart failure, 2 cats, one of which was euthanized, and development of seizures and death. 5 cats overall experienced serious adverse effects in this study, which included the 2 heart failure cats and 1 seizure cat in the high-dose group mentioned previously, 1 cat who developed DKA in the low-dose group, and 1 cat who developed a urinary obstruction in the placebo group. The urinary obstruction was considered unrelated to potential treatment, which was of course blinded at that time, and remained in the study. 69 adverse events were noted in total during the study, and there was no statistical difference in adverse events among the groups. Only 2 were considered likely to be associated with the study protocol, 14 considered possibly related, and the remainder considered unlikely or an unknown potential relationship to the study protocol. Mean age for the study population was 6 years, with a range from 1 to 12 years, which did not differ among the groups. There was no difference in body weight, respiratory or heart rate, quality of life scores, blood pressure, or biochemical testing variables among groups at baseline or any time during the study period. Echocardiographic variables did not differ among the groups at baseline. But here's where it gets interesting. By day 180, significant differences in left ventricular maximal wall thickness were detected among the groups on echocardiogram. Maximal wall thickness was significantly lower in the low-dose rapamycin group at 7.41 millimeters at day 180 when compared with the placebo group of 8.40 millimeters with a p-value of 0.013. Maximal wall thickness in pooled low-dose and high-dose rapamycin cats was 7.72 millimeters, and this was also significantly lower than in placebo cats by day 180, with a p-value of 0.054. It's important to note that the methodology of the statistical analysis in this study arrived at the conclusion that a p-value of less than 0.1 was considered significant, for those of you who noticed that the last p-value was greater than 0.05. A difference did not emerge between placebo and just the high-dose rapamycin group, however. Maximum left ventricular posterior wall thickness at any time point in the study was also detected to be significantly lower in the low-dose and pooled low and high-dose groups versus placebo. The study data also detected a statistically significant positive correlation between NT-proBNP at baseline and change in maximal wall thickness over the course of 180 days, such that cats with a higher NT-proBNP at baseline generally had greater changes in maximal wall thickness by day 180. In cats with baseline NT-proBNP of greater than 100 picomoles per liter, maximal wall thickness progressed more in the placebo group but did not quite achieve statistical significance, with a p-value of 0.11. These findings suggest that baseline NT-proBNP may serve as a predictor of response to therapy with rapamycin, which should be explored further. Baseline maximal wall thickness and cardiac troponin 1 did not appear to have predictive effect of response to treatment, but other predictors are yet to be explored. Looking back at the investigators' hypothesis, it looks like they hit on both of them. The data supported that rapamycin in both low and high dose forms appears to be well tolerated in cats with subclinical HCM, with relatively low overall rate of adverse effects, particularly serious ones. Furthermore, rapamycin in low dose form appeared to significantly affect the primary outcome variable of maximal wall thickness after 6 months of treatment when compared with placebo. This correlates with previous data in mice and humans with left ventricular hypertrophy due to pressure overload, although importantly, the pathophysiology between these two forms of hypertrophy is not exactly the same. In layman's terms, rapamycin looks like it may actually delay or reverse hypertrophy in cats with HCM. We haven't had cause for excitement like this in feline cardiac disease in quite some time. Prior mice studies have not only shown the physical reversal of hypertrophy with rapamycin treatment, they have documented normalization of abnormal myocardial gene expression in these mice. And although the data was predominantly in mice with pressure-induced hypertrophy, reductions in downstream protein synthesis has been demonstrated independent of pressure overload. Similarly, regression of left ventricular wall mass has been demonstrated in human renal transplant patients independent of hemodynamic load. The absence of a detectable treatment effect of high-dose rapamycin alone compared with low-dose treatment was postulated to be associated with the known effects of the dosing protocols as we discussed earlier. Intermittent and low-dose rapamycin appears to provide inhibition of mTORC1 without significant impact on mTORC2. It's worth noting that inhibition of mTORC2 can cause abnormalities of glucose and insulin metabolism. Now, one cat in the study did develop diabetes mellitus and ketoacidosis, although the cat was obese and potentially predisposed to it. While the largest number of adverse effects, both serious and non-serious, was documented in the high-dose group, this did not reach statistical significance. Furthermore, there is no way to know whether these adverse effects were related to the treatment group or to progressive cardiac disease, for example, like those cats who developed congestive heart failure. The authors acknowledge that this study is really a stepping stone with inherent limitations and creation of lots of additional questions, which is actually the mark of a good pilot study. A larger study is indicated, and underway, FYI, to try to reproduce these results in a larger population of cats. What effects, both good and bad, rapamycin therapy might have beyond 6 months in cats with subclinical HCM is one consideration. Another would be whether similar effects to those seen in cats with non-obstructive HCM would be observed in cats with the moderate or severe obstructive form of the disease. So, what do we take away from this VETgirl podcast? Well, first, know what rapamycin is. Second, know that it might be an option to help with HCM, as we don't have a lot of therapeutics right now. Importantly, the question also remains as to whether delay or regression of hypertrophy with rapamycin actually results in delay in time to onset of congestive heart failure or thromboembolism. I mean, it should, right? But just because it should doesn't mean that it does. And what about cats who are already in congestive heart failure? Would rapamycin help them? And would it be safe? Finally, HCM is a widely variable disease, both genotypically and phenotypically, so we can't simply assume that the effects of rapamycin will be applicable to all cats with the disease. So who knows if rapamycin may prove in future studies to be or not to be a one-size-fits-all kind of therapy, but isn't it great to think we may finally have a therapy to help slow or reverse this all too common feline heart disease?